So that's the, I don't want to be, too repetitious, as Andreas has given a really good explanation about the whole device, but you can see the evolution of the Lifetech devices from the heart arc to the Cera, which had this titanium nitride coating, to the CeraFlex with the special attachment system. There you can see a close-up of it with this essentially a double back suture, which has a mandrel that's able to slide backwards and forwards in the delivery cable. We saw a lot of the advantages. The titanium nitride coating is meant to prevent nickel leaching, which would improve endothelialization. Although I think there was a paper comparing the inflammatory markers between Occluders, Amplatzer, and CeraFlex, which didn't really show any difference in things like VEGF and other pro-inflammatory markers. And the other thing is the braided structure in the device means that the left atrial disc is flatter, which may be an adaptation. But I think one of the things is, and we'll see maybe a little more in detail, we saw the delivery system. It has the advantage that there's no screw and you don't have to screw it on, so it's straight out of the box, and it comes with its own loader, and you can use whichever sheath you prefer. We sometimes used it with the Cook check flow sheaths rather than the series, because it's sort of quite independent. You don't need to open a delivery system with its sheath. Here's the mechanism of how the actual series works. Here you can see on the handle you have the little red button, which you don't touch until you're ready to release, and then the blue button which releases the suture. And you can see, just if we let the cartoon run again, you can see how it works. As you pull back on the blue, you pull back this mandrel that's holding the suture in place. Okay, and here's, I think, maybe the biggest difference. I think if you can get a side profile of the device, you can see that it doesn't have the discs aren't clamped together as much. I think that's probably what makes it easier in terms of when you're dealing with a deficient aortic rim, because the discs are a little more separate. Then it doesn't prolapse through the aortic rim deficiency as much as, say, an Amplatzer would. And we'll see some examples of that. Felix Berger gave me some of his nice videos. So the Germans have done lots of work with this. And here's examples of the flexibility and stability tests on the series. You can see it's good and strong and flexible. We went through the dimensions previously with Andreas. And there's also a multi-fenestrated or cribriform version of it, which goes up to 40 millimeters. This is a cartoon of how what happens with the Amplatzer device, and we're all very familiar with this action. And it sort of became part of daily practice to the echocardiographer to wonder about the discs and attachment, often having to retract on the right atrial disc so that you can see the tissue that's caught in the device, and then seeing this sudden movement as you unscrew from the device. So we've got used to that. In terms of publication, it's still as a device relatively light on publications. And there really isn't that much literature on it. Obviously, when we write up the CeraFlex multi-center study, the European post-market surveillance, then we'll have significantly more devices published. But this was one published in Hearts in 2015, 125 patients, CeraFlex 58 versus Amplatzer 67, similar patient characteristics, really good results, 100% occlusion rate in both groups. In one Amplatzer, there was some transient left atrial hub thrombus, but there was no migration, strokes, or thromboembolism in any of the patients. Here they have the picture of how CeraFlex doesn't change angle when you release it. This was another study. Here they combined both Cera and CeraFlex with and they said the usefulness of the flexible rotation feature. They had 201 patients, ASD, PFO, In 7 children, they didn't do because either multiple defects or the septal length was too short, or they had a leak with 38mm balloon testing. The occluder was removed prior to release in 11 patients, and a successful implant in 183 patients. Follow-up of 1.8 plus or minus 1.7 years. No residual shunt in all of them after 3 months. 2 transient pericardial effusions and 5 transient SVTs in adults. No deaths, embolization or major complication. Unsuccessful in 11 patients, 5.7%, in all of which the occluder was removed prior to release. Cause of failure was unstable position during push-pull. Significant residual shunt after deployment in 3 patients whose basic atrium wasn't big enough to use a larger occluder. And there were 3 cases where the device obstructed either the coronary sinus, right upper pulmonary vein, or superior vena cava. And you can see in the picture there was one device with a conical malformation. This was a 22mm Ceraflex, so they obviously took that out easily and put in a 24mm instead. Felix very kindly gave me some of his information early on, and also some slides of device deployments. This is an example of a 10-year-old 33-kilo secundum ASD with right ventricular volume overload. You can see there's a very prominent eustachian valve there. A native diameter was 8mm and stop flow was 11mm. Put in a 12mm Amplatzer Septal Occluder, and this is the check prior to release. And this was what it looked like prior to release, and after release you can see the major alteration which the cartoon showed earlier. And there, that's what it looks like. We're used to that. It's a good result. We're very happy with that. We're used to the release. This is another case, 15 kilos, secundum ASD, RV volume overload, native 9mm, a small aortic rim and a small superior rim. Balloon sizing, stop flow 11mm, so not a big defect. Amplatzer Septal Occluder, and here you can see this prolapse that we're really familiar with, where it comes through at the aortic end when that's deficient. And we've also learned that if you implant like that, although you can release it, it will have migrated by the morning. Second attempt, same thing happens. Third attempt, even with trying to open the right atrial disc, similar, you can see it's still prolapsing. And then what to do next, your problem solving. Well, you could use the Hausdorff lock sheet. You could use a second catheter or dilator or balloon assisted technique. You could deploy in the pulmonary vein. I guess for us, we would usually just go straight to the right upper pulmonary vein and use a root technique, or use a larger device. But so instead they switched to Ceraflex 12mm ASD device, and you can see the device does have very different edges when you look at it echocardiographically. You can see it's much more of a H-type effect here with rounded, blunted edges. I think that's probably what helps it to actually not to come through the defect. It also means it's softer in terms of avoiding erosion. And there you can see the effects. And that's just after one attempt, and it's dealt with the aortic problem nicely. And this is, and there you can see the difference in shape. In reality, it actually has a very different shape to the Amplatzer Septal Occluder, which you actually see better on fluoroscopy than you do when you're examining the device in your hands. And that's it released. And follow-up echo. Another case with a small rim towards the atrial roof. This is an older man, 26 years, 56 kilos. Sized at 27mm and a 28mm Ceraflex, orientating very nicely, and that's after release. Another example, a bigger man, 102 kilos, with a floppy posterior inferior rim and missing the anterior superior rim. Stop flow balloon sizing 21mm, 22mm Ceraflex. Prior to release, and really very little change with release. and that's what it looks like on 3D, nice and flat. So the German Heart Center, this was September 15, so this was a while ago. These were the numbers they'd done, 14 patients, so small numbers. In terms of Dublin, to the similar stage, and since then we've done a fair few more. There were 78 patients between May 14 and December 15, and this was it was Children's Hospital, so this was the range. Mostly secundum ASD, a few atrial fenestrations. That was device size versus weight, so you can see the most common sizes. TOE size, balloon sizing, and result, complete closure 70, small residual, device migration in 1. I think that patient, went to surgery then. I don't think we had the Maslanka, or at least we didn't try. Trivial residual. And this is taken from your paper, Andreas, showing a very nice paper. This was to me was the most interesting aspect of it in terms of the Maslanka forceps. This was a device deliberately embolized in an animal in the right ventricle. And what you needed to do it, going straight with the Maslanka didn't work. You needed to go with an ordinary biopsy forceps or snare to stabilize and pull back the device, and then catch it with the Maslanka as the final strong pull into the sheath. So that's an important thing to have if you're using devices with small hubs. There was a concern early on, and I think it was that you could have a tulip malformation in much the same way as we had cobra malformations. And in fact, when we started the Lifetech study, we had to stop it for a while because of device availability, because they were concerned that there could be this tulip malformation. But the reality is that tulip was related to probably device oversizing in the defect. So to conclude, our early medium-term experience with Ceraflex is very promising. There's a high occlusion rate. It's a flat configuration, flexible implantation characteristics, very little position change. I think it's a big advantage in the deficient aortic rim. You can do less of these pulmonary vein maneuvers. It has the disadvantage of needing a larger sheath, 1 to 2 French. There really aren't a huge amount of publications of it. Hopefully that will change. And in terms of erosion and endothelialization, we've already talked about that. We're not certain about that. Hopefully it will be very little. So thank you very much for listening.